All right, I'm very happy to introduce Dr. Anita Souza, who is a clinical professor at the University of Washington School of Nursing. Her program of research focuses on improving care for older adults across the cognitive continuum, with a particular emphasis on those in rural, tribal, and underserved communities. As the age-friendly outreach coordinator for the Northwest Geriatrics Workforce Enhancement Center, Dr. Souza partners with rural healthcare systems utilizing principles of community-based participatory research to advance age-friendly care. And with extensive experience developing rural clinical placements and fostering community academic partnerships, she's very committed to strengthening the rural health workforce and promoting age-friendly approaches to care for older adults. So, Dr. Souza, welcome, and we look forward to hearing about age-friendly healthcare in the 4Ms.
Thank you so much, Barb, for that kind introduction and for the opportunity to kick off the annual Jerry series. So before we leave this slide, I'll share that I pepper throughout my slide deck images from the rural communities in Washington where I have collaborated with those rural healthcare systems to receive age-friendly recognition. This particular picture is a majestic aged evergreen tree just outside of Forks, Washington, and it's where the Forks Community Hospital system received age-friendly recognition for all of their primary care clinics, which included 3 primary care clinics that served their area. So we have 3 learning objectives for today's conversation. I'm going to describe and explain the components of the 4Ms framework for age-friendly health systems, and then we're going to analyze the development and current progress of age-friendly health systems initiatives, both nationally and here locally in Washington, with the hope that it'll be applicable from wherever you might be joining us from. And then we're going to apply age-friendly principles to an interdisciplinary case study that will give us a little opportunity to be interactive through the chat mechanism. So, okay, one last orientation piece before we dive in, because there's a lot to cover here. And we'll begin with the background of the age-friendly movement and a discussion of where it is currently, looking at the evidence base for age-friendly approaches. Then we're going to dig into the 4Ms, what they look like operationally, and through that application of a case study that I hope will provide you with a little bit of food for thought on how you might apply this to your own area of focus, wherever that may be, and whatever your role in the healthcare system may be as well. So why does age-friendly matter? Age-friendly is a movement, and it's an approach to serving adults that truly benefits us all. And this is a list of 5 forces that are disrupting and transforming healthcare today. And they, again, impact us all. This data comes from a joint study by the John A. Hartford Foundation in partnership with the Age Wave and Harris Poll. They polled 5,000 Americans, with half of them being over the age of 65. And this first one here, the demographic shift, probably doesn't surprise anybody who's in attendance today. We are certainly aware of that demographic shift. And it's the number of older adults in relationship to the number of younger adults, younger individuals. And those age 65 and older are the fastest growing segment of our population. In 2030, just a few years from now, adults over the age of 65 will number 71.2 million. And these numbers really emphasize the needs for our health systems to begin to align more closely with the unique needs of this population and to embrace age-friendly models of care. The second one, health-adjusted life expectancy. So behind those numbers is another story. With longevity, it does not necessarily follow that all those years will be in good health. There's a good chance that it won't. The amount of years that people can expect to live free from disability is what we mean when we're talking about that health-adjusted life expectancy. Unfortunately, the US numbers are concerning. We rank 68th in the world, and this means that adults in the US spend the last dozen or so years of their life in poor health. It looks like 14.3 years for women and 11.1 years for men. We also, no surprise, have a very fragmented healthcare system with high costs and many inequities. So talk to any older adult about their experiences navigating healthcare, and you'll hear the true impact of these failings. Medicare, Medicaid, as well as the constant shifting of healthcare plans lead to changes every year for older adults, with some adults reporting that they spend most of their time trying to navigate or understand the healthcare system, either for themselves or for a loved one. The access to primary care providers is also extremely limited, and care is often very uncoordinated. All of this is compounded by inequities in access to care. COVID really highlighted for us the healthcare workforce shortages that have not gotten better. In fact, are looking pretty challenging as we face the future. Our workforce is very fragile. We're expected to have significant shortfalls in nurses, physicians, nurse practitioners, and this coincides with ever higher healthcare utilization needs due to that aging population. And unfortunately, adding to those realities is a finding that only 1% of physicians are geriatric specialists, and currently only 10% of medical schools require geriatric rotations. And we look at that in contrast to pediatric rotations, where 96% require those rotations. So we can certainly see the value in having that lifespan focus on both ends. But we'll end on a high note with the advances in medical science, AI, and healthcare delivery. Many advances have been made on those fronts on the healthcare side, but also directly to patients in the form of healthcare apps, trackers, the availability of virtual visits. And in many ways, this has improved access, though disparities still exist. And older adults are also increasingly adopting these modalities, engaging with the technology, which is really exciting. And I saw we have Oleg Zolitsky coming from the School of Nursing, really excited. He'll be talking about those technologies as well. Looking forward to that. So let's take a look at some of the additional perspective from older adults that participated in the study. This bar graph, it looks at the experiences of adults over the age of 65 who identified as having a primary care or regular healthcare provider. And it asks questions about their routine visits and whether or not they were asked about the domains of age-friendly care during their visit. So on the top bar, blue bar, you can see asks how I'm doing with my medication. 71% were asked about that. But if we look down below at the asking questions to understand what matters to me in terms of my health and well-being and evaluates my mobility and fitness, just over half were asked those questions about what mattered to them or were evaluated for their mobility. And further down, we have less than half that were evaluated on their mental health and their cognitive health and cognitive functioning. And those are some key areas for older adults, things that they want to talk about, want to be asked about, and need to engage with their providers on. And this 19 asks about the 19% of all of the above, asks about all of those components and whether or not they were asked about all of them during their healthcare visit. And only 19% were asked that. And so that gets to where we're going with the age-friendly discussion, that all of those components need to be asked during those healthcare visits because they are all important. So again, looking at that older adult perspective in age-friendly care, let's keep that 19% in mind and look at this graph. That talks about those who received age-friendly care and those who did not receive age-friendly care. So those who received age-friendly care are in yellow on this graph. Those who did not are represented in the blue. And again, it's looking at the full complement of age-friendly care during their healthcare visit. So those first two bars look at satisfaction rates, both in rating their healthcare provider and in rating the quality of the care that they received from that provider. Age-friendly approaches increase those satisfaction ratings. And it's no small thing, as that satisfaction can lead to stronger health promoting behaviors and a stronger relationship with your healthcare system and your healthcare provider. And we see this in the third set of bars, where individuals who received age-friendly care reported engaging in healthy habits such as exercise, health, healthy eating, socialization. So those gains are seen with overall health ratings. So it definitely highlights the benefits of an age-friendly approach in the healthcare setting. The age-friendly evolution has come about. It started it's been a discussion for a very long time, but more formalized in 2015 with the John A. Hartford Foundation, when they developed and formalized that concept of age-friendly health systems. And it was really a goal to improve the healthcare outcomes for older adults in all the varieties of healthcare settings in which older adults engage. And they built upon previously identified successful practice models. And in 2016, they were really spurred into action by knowing that 10% of older adults in the US were being served by evidence-based models of care. That was far below the standard of what we were hoping for, with only 10% receiving that evidence-based care. So in 2017, the John Hartford Foundation approached the Institute for Healthcare Improvement, and they partnered in that year to develop the age-friendly health systems. And it really created a movement that could transform healthcare for older adults. This movement is absolutely in harmony with other movements that we see, such as the dementia-friendly movement, the age-friendly cities movement. And here where I'm based in Seattle and in Washington State, those are thriving movements that represent the development of an age-friendly ecosystem. And this perspective places age-friendly within that ecosystem, but there's so many parts of that system. It's our workplaces, it's our public health systems, it's our research institutions. So I think we can all definitely agree that embedding this within multiple systems is an important goal, which really leads to desirable outcomes for older adults. So in formalizing the age-friendly health systems, IHI developed 2 levels of recognition for all settings: inpatient, ambulatory care, and nursing homes. Level 1 is referred to as participant, and we're going to walk through a little bit what that looks like in our case study. In each of the 4 M's, IHI has recognized metrics for health systems to employ to match to one of the 4 M's. But this level of recognition is really about a health system engaging and supporting them in building their infrastructure to ensure age-friendly practices. Level two typically happens with at least within 3 months they start the process within 3 months of receiving age-friendly level 1. And it looks at identifying and quantifying how many individuals over the age of 65 are receiving age-friendly care. So it's about striving towards meaningful and consistent implementation of the 4 M's in their healthcare setting. The recognition system is really deliberately designed with a relatively low bar to entry. And this is really intentional to allow as many organizations to rapidly begin their age-friendly health systems journey and scale them up with support. They provide a tremendous amount of support to organizations who are wanting to engage. And it also aligns with the work of our Northwest GWEC, which is to support rural and underserved sites that are seeking to attain that recognition. So here we have a map that highlights the impact of the age-friendly health systems initiative. The adoption has definitely grown exponentially. In 2025, we had 5,647 sites that received age-friendly recognition across levels 1 and level 2 nationally, but it's also an international movement as well. I just didn't include that map, but it's great to see that growth nationally and internationally. So shifting the focus a bit more to our local Washington State area, I can share a bit about my work and the focus that I've had as part of the Northwest Geriatric Workforce Enhancement Center. So as you can see, the age-friendly health system recognition here, these are the dots of where age-friendly recognition had been attained prior to us receiving our funding in 2024. So primarily what you're seeing here in those dark blue dots are nursing homes. They represent 84% of the recognitions in Washington state at that time, with 3%, only 3% being those outpatient settings and 13% being those inpatient settings. And what you also might notice here on this map is that those dots are primarily in those urban areas surrounding in the Puget Sound area and some a little bit more over in the Spokane area, but not a lot in our outlying rural regions. And our grant has focused on those rural and underserved parts of Washington state and looking at increasing those numbers. And this is so important because the demographics of our rural communities are older adults. And I know we have folks on this webinar that are from outside Washington state. So these slides are not intended to be Washington-centric in their message, but a little bit more to say that that rural focus is critically important no matter where we are, because those are representative of older adults in our communities, and it's really important to expand the reach of age-friendly. So this map is representative of year one of our grant, which ran from July of 2024 to June of 2025. And we can see the pie chart changing a little bit, with us taking up a greater portion in that outpatient by having more sites that receive that age-friendly recognition at 10%. Inpatient at 13%, and nursing homes at 77%.
Anita, a question has come up about the orange dots. What do they represent on that slide?
Oh, these orange dots were, I think that there's an error in the coloring, but those are previous sites that also were nursing homes.
Thanks.
Thanks. And so we are now in year two of our grant, and we have rapidly been adding more age-friendly sites as well. To date, in year two, we have currently added 17 additional sites, and those are represented here in the yellow dots and then the purple dot, and some names here that you might recognize if you're in the Washington area is a Harbor Regional Health System. They added 4 outpatient and 1 hospital, so really representative of their comprehensive health system adopting age-friendly. Valley View Health Centers with 7, it's actually 9 of their outpatient sites are age-friendly, and Ferry County Public Health District also looked at all of their health service delivery from inpatient, outpatient, and nursing home. And they have recently all received recognition. So all of these are level 1 participant recognitions in Washington state. And if we look at the impact for levels 1 across those 2 years of the grant, it's really exciting to see. So seeing which were the GWEP sites which were previous to GWEP, and that we're starting to have those dots, those purplish pink dots, populate across the Washington state area in those outlying areas. And I think it really shows the response from the health systems that has been terrific. They've been excited about it, and that they see the importance of age-friendly, and they're really eager to accept it. A common response that I get from administrators and providers is really that this is the right thing to do. It's the right thing for their community. It's the right thing for their patients. And that's exciting to see. Okay, now with that background and hopefully a little bit of excitement around that momentum, let's get to some of the nuts and bolts of what age-friendly care actually is. So these are the 3 principles of age-friendly care. They underpin our decisions and our behaviors. They don't necessarily prescribe exactly what needs to be done in each situation and setting, but they help us to know how to partner with older adults. So age-friendly care follows an essential set of evidence-based practices in a framework known as the 4Ms. Age-friendly care causes no harm, and age-friendly care aligns with what matters to the older adult and their family caregivers. With those underlying principles of the framework, it focuses on 4 main areas: what matters, medication, mentation, and mobility. So we're going to unpack each of those in just a few moments. But more broadly, let's look at the integration of age-friendly in the 4Ms. It's important that age-friendly and 4M care happens with every older adult at every healthcare encounter. That is the intent of age-friendly care. And the process of age-friendly care should be exercised regardless of the presence of cognitive challenges or health status, be it excellent or poor, and regardless of socioeconomic status and identity. It's really important to look at what biases might be present for us in our interactions with older adults, because those biases prevent the intention of age-friendly care or have the potential to impact the intention of that age-friendly care. So it's important that we know about the 4Ms for each of the adults under your care, and not only to assess and know about it, but also to act upon it at each visit. So honestly, it can seem like a tall order, but really each of the 4Ms, I think you'll see, are so interconnected to the overall wellness of an individual. And it's an opportunity for us to look more holistically at individuals and really not be looking through those myopic lenses and missing the value of the whole for that aging individual. So to approach the 4Ms, IHI has broken down the implementation of those 4Ms into 5 key areas to consider in healthcare settings. So first off, starting off with assessing and screening using evidence-based measures. So if we recall those earlier slides where only 45% of individuals were asked about their mental health and only 40% were asked about their cognitive health, age-friendly health systems brings this into focus by not just asking about, but by employing evidence-based measures in those areas and using those evidence-based measures to ask about their depression or what their cognitive health might look like. And the frequency matters. So we're typically looking at a minimum of reviewing the 4Ms at every visit, every healthcare visit, but also at every change of condition for an older adult. And for much of this presentation, I'm going to focus on primary care settings, but there are some areas where, say, in the inpatient or in the nursing home, where that's going to look a little bit different, and I'll try and touch on those as well. So in frequency, if we're looking at the inpatient, there's some measures that we look at with a little bit more frequency, and that makes sense based on the acuity of the setting. And an example of that would be delirium, where you're looking at doing a delirium screening every 12 hours for an individual who's in a hospital setting. Documentation. This typically happens in the EHR. And a challenge that I see in a lot of health systems is that they're asking the questions, they're doing the work, but they're actually maybe missing in the documentation of that. And oftentimes it's a structural issue, as it was not built into the EHR, or there's a lot of limitations around the EHR. But it can also be a consistency issue due to lack of a defined process within that health system. And documentation also supports us being consistent and providing that consistency of care across all settings. And that always works well when the EHRs talk to each other across systems, but we know that doesn't always happen. But it's lovely when it does. And act on, that again varies by the setting and by the type of 4M that we're focusing on. And primary responsibility, age-friendly, is really a shared community value in a health system, and it's reflected in the healthcare team with interdisciplinary responsibility for implementation across many individuals. So IHI has really come about the standardization of age-friendly care, but also looking at it from a systems-based approach. And I encourage you to take a link at the look at the link that I've provided here. It will take you to IHI's application, and you'll be able to see the applications for the hospital, the ambulatory care setting, and the nursing home, as well as several others. And see what that consistency looks like, what the application process looks like for sites. And it's really a wonderful way of creating that consistency and normalizing age-friendly care in a way that can honestly, hopefully, mitigate fragmented care that we discussed earlier. So looking at some team-based approaches for implementing age-friendly care, really making this visible across the care team and across settings. So creating systems, protocols based around the age-friendly and the 4Ms. So what gets standardized does get done in many cases, and make it a practice norm within an organization really helps to move that forward. Making the 4Ms a part of daily team discussions. It can be helpful to make it a part of those team discussions, especially when you're shifting the culture and your organization is trying to align with these principles. And I think it's so important to discuss the partners in this, which are those older adults, and educating older adults, caregivers, and the community about the importance of the 4Ms. As part of our grant work, we celebrate and provide notifications quite broadly for health systems that have received age-friendly recognition. We provide them with framed certificates as well as window clings, and they're able to put those window clings on the clinic doors or hospital doors and where the patients check in. And these are really outward acknowledgments of the commitment that they have made to their community to be age-friendly. Okay, let's dive into a bit of a case study. This will be a little bit more back and forth in the chat, hopefully, that we'll have that opportunity. But this is a case from a primary care perspective. And to set the scene, this is a primary care visit in rural Republic, Washington. So for those of you not familiar with Republic, it's on the northeast side of the state near the Canadian border. It's about 2 hours north of Spokane and about 6 hours from Seattle. So the real names have been altered, but the pictures are unique to this beautiful area. So Carl, he's a 78-year-old retired hard rock miner who presents to his primary care clinic for a routine follow-up. He's accompanied by his son and daughter-in-law who live 2 hours away in Spokane and serve as his primary contacts. Carl lives alone on a small rural property where he cares for 2 dogs, an aging horse, and a few chickens. Caring for his animals, in his words, are what keeps him going. He retired on disability after a serious fall underground about 10 years ago that caused chronic back pain and ended his career. He remains proud of his decades as a miner and still socializes with former coworkers at a local cafe. Carl has a history of alcohol use disorder, now drinking 2 to 3 beers on weekends, and his son worries he sometimes drinks more when lonely. He continues to drive locally, avoiding highways, though his daughter-in-law reports he recently missed a turn on a familiar road, and neighbors say he drives very slowly. He denies having any accidents or near misses. So keep some of the components of Carl's story in mind as we move forward in walking through the 4Ms. So starting with what matters. What matters is about knowing and aligning the care of each older adult's specific health outcome goal and their care preferences. And it's really about including, but not limited to, end-of-life care. So it should not only focus on those end-of-life care discussions, it should focus on the here and now and what's important, and across all settings of care. And the statement from Karen Bullock really resonates with me. She says, countless times I've heard clinicians say, I treat all of my patients the same. But how do you know what matters to a patient if you're treating them all the same? I think we've all likely had the experience of being a patient at one point in time and having a medical encounter. And we do want our provider to see us uniquely and to know what matters to us. And that is a critical, the foundational step of the age-friendly health system. And for the 4Ms, what matters, when you're going through the age-friendly recognition process, they are encouraging you to identify what questions you routinely ask older adults. And these are some variations on what the IHI is looking for. So what is important to you today? What brings you joy? What makes your life worth living? Setting goals for the 6 months or before your next birthday. And what would make tomorrow a really great day for you? Again, frequency is important. We're asking these annually or upon a significant change in condition for individuals. And it sets the foundation for the care plan and is consistent with other initiatives such as the patient priorities in care, which supports those healthcare decisions and making patients' priorities the priority. So for many older adults, they're managing those multiple health conditions, and making care decisions is complex. And so identifying what matters is important in helping them balance those trade-offs in their care decisions. So let's use the chat feature. And Barb, if I could call on you to help me keep track of it a bit. We're going to think about some questions with Carl. How would you engage with Carl on what matters?
I know it takes a little bit of time to kind of frame a response for the chat. Feel free to incorporate the other two questions in your...
Yeah, absolutely. Thinking about what prompts you might consider.
So Cynthia Knight said one thing would be, tell me what a typical day looks like for you.
Absolutely. And Sue, you've identified staying in his home might matter. LaQuinta, I would ask him how his day-to-day activities are with his animals and caring for them. What do you like to do for fun? Those are really great questions to start engaging with Carl and getting him to open up on what matters to him.
These are great questions.
They're wonderful. Oh, sorry for looking away. I have my chat on the other screen, but it's exciting to see it populating with so many rich thoughts. And definitely, you all seem very comfortable in asking these questions and thinking about what you would ask, and knowing that maybe this has not been a healthcare engagement encounter that Carl has had previously with other providers. So sometimes it takes a little bit of coaching to encourage folks to share about what really matters to them, and knowing that what matters, again, going back to what we want to do in the frequency, is ask this frequently in our visits with older adults and across those different healthcare settings, because what matters changes as your health changes, as your family situation changes. It might change for you as to what is going to be that priority for what matters. Oh, what brings you joy? What's difficult for you? I love that. What are some thoughts on who is responsible for asking this within a primary care visit? Yep, excellent. LaQuinta, with all team members being responsible, absolutely. This conversation can happen at each level of the encounter with the patient and the older adult. And again, making sure that that is documented in the EHR as to what matters for them. Some things that we want to avoid are assuming that we know what matters for Carl. Expedience sometimes leads us in this way in those encounters, but it's really about exploring this question with Carl and helping him to guide that care in a way that is most meaningful to him. Thank you so much for all the engagement on that question. We're gonna continue with moving forward to medication. So if medication is necessary, it's about using age-friendly medication that does not interfere with what matters to the older adult, or their mobility or their mentation. And so medication is the 4M that is really intertwined with all other aspects of age-friendly care, such as cognition, mobility, and what matters. They're all interconnected for sure, but this one is very interconnected. And a little bit of the why on medication. So 4 in 10 older adults take 5 or more prescription medications, and 20% take 10 drugs or more. And this can lead to increased hospitalizations, as well as we know that drugs affect older adults differently. And we also have an upcoming talk in the Geri series specifically about medications. So let's look at what the age-friendly health system is identifying for screening and assessment using those evidence-based measures. So at a minimum, they're looking that you are doing the Beers criteria, which really incorporates all 8 of these medications. So identifying these high-risk medications for older adults. And that the frequency is at least annually and upon significant change of condition. And an additional add here is at the change of medication, which makes good sense for sure. And then acting on that is educating the older adult and their caregiver about the medications, excuse me, and deprescribing. So dose reduction and medication discontinuation when that makes sense for the individual and what is happening in their health profile. So let's turn our attention back to Carl again. A little bit more information about Carl now. So he's on metformin for diabetes. He was diagnosed 3 years ago. And he discloses that he still has some leftover medication from his prior surgeries, and he uses these from time to time. This includes oxycodone that he uses for pain and occasionally Valium for sleep. He also has a local herbalist neighbor who provides him with a memory supplement. What questions would you be bringing up now and thinking about for Carl? And I'll turn again to my chat that's on the other screen. So what are your thoughts about continuing this conversation about medications and what maybe is a red flag that you're seeing? See, Lakeisha, about that most don't need to be on excessive medications. Yeah, we'd want to know what those herbs are. What's in that memory supplement? Ask how often. Absolutely. The opioids and the benzodiazepines. Yep. Jade, yes. The unaddressed pain and insomnia. Why is he self-medicating for those? How can we help with that? Jordan, your comment's going to come up in the next slide, I think. Sue, looking a little bit more at that pain. What does he experience when? Yeah, and that you're going to talk about it as a team. And I think, Amy, discuss how the opioids and Valium affects older adults and offer safe alternatives. I think absolutely that gets to what we want to do in the act on in the educating the older adults. Perhaps Carl's doesn't know the risk that he could be having with the oxycodone and the Valium. So all fantastic, fantastic comments. Let's move into mentation. So mentation is to prevent, identify, treat, and manage dementia, depression, delirium across the settings of care. And why is that important? So for a whole host of reasons, but only 40% of older adults say that their doctor regularly evaluates their cognitive or brain functioning. Yet the data shows that cognitive health is a significant concern for older adults. And again, as I mentioned before, it's one that they want to talk about with their providers. It's about bridging the opportunity to have that conversation in some cases. So in age-friendly health systems with mentation, this is what it looks like. This is a busy slide with a lot of information, and that's because for mentation in the primary care setting, it focuses on two domains. It focuses on both mind and mood. So there's a screening focused on cognitive impairment, and we're looking at screening using these validated measures. And when it says a minimum requirement, at least one box must be checked. I'm including that language because that is what IHI is looking for on the age-friendly recognition. You must be using these evidence-based forms, and these are the ones that they have identified. Most of these very familiar to us. Mini-Cog 88, BIMS, they are utilized, certainly the Mini-Cog in our annual wellness visit. So they're very well known and utilized within the primary care setting. And then assessing with the slums, the MOCA, so on and so forth. And again, they are well known, but are they well utilized? Then we're also looking at depression and screening and assessing for that as well, with the PHQ-2 and the PHQ-9 and the GDS. And it would look a little bit different for the mentation in the hospital and nursing home. Again, as I mentioned, that those screenings are going to focus on screening and acting on delirium that is more prevalent in that setting. So for the mentation, looking at the frequency, it's going to be at least annually and on significant change of condition. And acting on is going to be about sharing those results with that older adult and having those conversations, providing educational materials to those older adults and their caregivers, and referring to community organizations for education and for support. And for those, you know, this is one of those areas where AI and the technology advances have certainly supported us, but we want to provide accurate information to families about dementia and also provide them to those resources. Think about Carl's daughter-in-law and son, and whether or not they could maybe attend a caregiver group remotely. Those are some things that are available to us now that have not been previously available. Depression with the frequency, at least annually upon significant change of condition, and also educating adults and caregivers and considering the recommendation of an antidepressant when it's warranted. So again, we're in the swing of it now, I think, with looking at the 4Ms in practice and focusing on that mentation piece for Carl. So in the cognition, here's a few more details to add to what we know. He's missed a couple of bill payments and has gotten lost driving home from the town store, which he admits during this primary care visit. And he says he does feel a bit lonely at times. And we know from his disclosure and then also disclosure from his son that there is some ongoing alcohol use and cravings. Caregiver's perspective is he repeats his stories, he seems a little bit more withdrawn, and we worry about him driving. Thinking about this, what thoughts might you have about Carl? Discussing care plan with family and team. And we can see in the mentation how it's really important not to have a rush to judgment on what is happening with Carl. We know that the medications is very involved also in mentation. What's happening with maybe the memory supplement that he's taking, all of those high risk medications. So how is that creating a complex cognitive situation for him? Jordan, definitely asking more about the alcohol use. Getting to the loneliness and looking at what activities outside of the animals and things to look at. I like your approach, Rebecca. Yeah, companionship care. So thinking ahead as to what might work for Carl, yeah, looking at screening and tests. All of that is definitely critical, important, and we can think about those numbers of people who are not asked. You guys all presented such important, rich questions that we would want to know in order to support Carl. Imagine not having those conversations and missing those opportunities to have those conversations. So the 4Ms mobility, this is our last of the 4Ms, and it's about ensuring that older adults move safely every day in order to maintain function and do what matters. So why is that important? Mobility is what keeps us active. And we know that 1/3 of 70-year-olds report restrictions in mobility in their daily life circumstances. And that has implications for their overall health. And it does lead to increased fall risk, injury, and hospitalization as well. So while we might feel really comfortable asking about fall risk, falls are important, but it's not sufficient. We need to go further. We need to be focusing on ensuring early, frequent, and safe mobility for older adults. And we want to support those older adults in maintaining and retaining their mobility and also setting daily goals around mobility. We can see how this easily ties with what matters, bringing us full circle again. If someone shares that they love attending their granddaughter's basketball games, it's important that we now have that knowledge and the tie to mobility and helping her to meet that goal of attending those basketball games. And that might start with a simple daily walk. So thinking about Carl and mobility, more details are starting to emerge about him. So Carl reports walking on his property daily to feed his animals, but he has chronic back pain and that limits bending and lifting. And he shares that his home has limited outlets, so he uses extension cords and has had a couple of near falls in the past couple of months. Given this, what priority areas are you thinking about for Carl, both in questions you might ask and thinking ahead for Carl in the future? Some thoughts about Carl with mobility? Looks like they're coming. Definitely fall prevention, maybe a PT referral. Home safety eval. I think this is one of the areas where we really start also to think about challenges that occur for older adults in some of these rural communities. In one, going back to that health workforce, in are there physical therapists that are available for those visits? Are they able to get, if it's not a home visit, are they able to get to a PT visit? Looking at evaluating. Oh, looking at how you're taking care of your body during those chores. What strategies do you use to keep yourself safe? Yeah, what body mechanics are you using? Wonderful thoughts. Yeah, looking at alternatives to the extension cords in the home. Extension cords are pretty prevalent and in home visits when I used to do those, and seeing all of those numerous extension cords and then seeing carpets on top of them that bring fire risk as well. So all important things to be thinking about in the mobility realm. And from the age-friendly perspective for IHI, they're looking at a minimum of checking at least one of these boxes on tests of mobility, screening for mobility. So most common is the timed up and go. And then also looking at the frequency. So annually for mobility as well as significant change of condition. And then this act on gets to many of the comments that you guys have put in the chat, which is looking at prevention protocols, educating the older adults and their caregivers, looking at those issues of pain, balance, gait, strength, educating on correct body movement. I love that. And ensuring that the home is safe, a safe environment for mobility, and that might involve some changes. Identifying and setting those daily mobility goals for older adults. And again, the interconnection of going back to the M focused on medications. So avoiding those high risk medications that can potentially cause an increased risk of fall for older adults. And then referring to physical therapy. So thinking ahead about Carl, we know he lives in a very rural community. If he remains in that community, if he remains in the community in Republic, he has a health systems that has age-friendly coordination across all of their settings. So in that inpatient, in the outpatient, in the nursing home. So I hope this exercise in talking a bit more about Carl helps to illustrate the value and approach to this care and why it is so critical for individuals like Carl, but also for Carl's caregivers, his daughter and his daughter-in-law, or son and his daughter-in-law.
I was going to point out one of the chats Sue Warren mentioned contacting the area agencies on aging, or what we call the AAAs,
Hmm.
because they are available to provide home assistance and have people come into the home to make assessments. And also, Carrie Nagel mentioned, um, you know, a broad base of disciplines can get engaged in helping somebody like Carl, and mentioned that they found OT to be helpful in discussing body mechanics in a home setting.
I love that. That's wonderful. Yes, great suggestions. And a lot of wealth of experience in the chat. Really appreciate that. So, lastly, just looking at barriers and solutions and having a little bit of that discussion, which M do you think would be the hardest to implement in your setting? In your work environment, or maybe you're a caregiver, and which M is the hardest to implement?
What an intriguing question, Dr. Souza.
I can say that from folks in the health systems, just talking through all of those four M's, it's really that they worry most on the onset about the time that it takes to have those four M's conversations. And so maybe it's not just one, but it's the collective um, weight of having those conversations. But I hope we've gotten to a point where we can see how valuable and how that they can actually make subsequent healthcare visits a little bit easier in knowing this knowledge. Getting a client to be willing to talk about depression and cognition. Yeah, I think very true. Mm. Lack of resources for the geriatric population, and especially the rural and our more underserved challenges as well. Isolation, loneliness. Mhm. Any ideas of where you experience some interprofessional gaps in addressing care for older adults, maybe more broadly than just the four M's? Mm. Sue, you think you bring up a challenge. I think that the PC providers are not all comfortable with the cognitive assessment. Hmm. And perhaps it's with comfort with the discussions that come after. Yeah, and gaps in community, transit. Mm. Carrie, the discussion of the patient advocate also very good. It's nice that there is a family member to go, but with Carl, but that's often not the case. Staff resistance to change care strategies. Yes. In the implementation of the four M's, when it's new to an organization, we really encourage that there is a champion who's leading that effort, because there are challenges. And also, going back again to the health workforce, that things change so frequently with the profile of your healthcare providers. You might lose three nurse practitioners, have another three nurse practitioners all in the same year. And how do you keep that consistency of four M's care continually trained across those new hires? Which M is most frequently missed in your setting? Any additional thoughts for Carl or for this situation or for age friendly in general? Or Barb, have I missed anything in the
Well, I was
comments?
just going to say, I hope you'll forgive me for saying or asking folks, to what extent do you think that the what matters M is missed in the settings?
Mm-hmm. I think the data shows that the M's are infrequently, unless there's an age-friendly focus, definitely that mentation is missed a lot, mobility, all of them are. And the what matters discussion, that foundational discussion is often frequently missed. So I'm not sure if that resonates with what you guys are experiencing in the settings that you are coming from. So Carrie, the what matters is rarely brought up. Ms. Quinta, I love that you're bringing up all of the medication mentation. Mhm. Maggie, definitely. Yeah, and Amy, all of them. I think we definitely see that in the data that often all of them are missed. Yeah, Lisa getting the POA and advanced directives in place. Mhm. Well, thank you all for your very rich engagement in the chat. And it was wonderful to hear all of the wonderful experiences that you have and how you are working in your communities around age-friendly care. So thank you for this opportunity, and we can open it up for some more general questions. I can keep an eye on the chat, but you're also free to email me as well. And I believe the PowerPoint slides will be available to you as well. I'm going to
What
stop
questions do
sharing.
you have? Did you see David's question, Anita,
Oh,
during your introduction?
yeah. So, David, you're asking about the 14 years for women and 11 years for men. And so, what those statistics were referring to is your years that you spend with a significant health disability. And so, that's looking at those margins in your life at the end of your life. That it's typically 14 years for women that they might have one or more serious chronic conditions that limit their activities, and 11 for men. Again, we're hoping we're changing the dial a little bit on that.
I like
Oh,
Carrie's.
I like Carrie's too. The years ago, an acupuncturist asked me what I did for fun, and it stays with me to this day as I realize I'm way too serious. I like that. I also like that the acupuncturist saw beyond just that visit and the reason that you were there and asking. That's
Yeah.
great.
So, Anita, Maggie Pheasant had asked fairly early on, and I held this to the end, a question about are medical and nursing schools encouraging ARN, PRNs, and paraprofessionals in clinics to specialize in geriatric health? Do you have a sense of that? How schools are doing in terms of encouraging folks to go into geriatric care?
Certainly, the School of Nursing, we are encouraging it, one, through this grant, where we provide traineeships for nurse practitioners. And what that looks like is that they spend a clinical two actually, clinical rotations out in rural and underserved areas focusing in geriatrics. We also have in our nurse practitioner program, we have AGNP. So that stands for Adult Geriatric Nurse Practitioner. We have two tracks of that. We have the primary care and we have the acute care for geriatrics. So I think it definitely is a focus. It's a focus of our curriculum at the School of Nursing as well. I can't speak as well to some of the other schools, though I do know that from what I know, the nurse practitioner programs just nationally for accreditation do focus in that lifespan care in geriatrics.
Well, I can say that again, this is the focus at UW, but other universities also have other centers and focus that address aging. Our School of Pharmacy has a geriatric pharmacy certificate program with quite a few students engaged in that certificate program. We do in the School of Nursing have the Deterny Center for Healthy Aging, which encourages a focus on aging. And this funding mechanism, the Northwest GWEC, is actually funding some work to provide a one credit course for students to get some experience and some background in long-term care to start considering that as a career. This is for undergraduate nursing students that we're working with in that program. It's a course that's offered one quarter each year, and we just finished up our last offering of that for this year, and then it'll be offered again in fall of 2026. And our program is also in the early stages of developing a program requirement which involves an apprenticeship program for certified nursing assistants to be to receive some training as more advanced geriatric specialists than what they might have in their general CNA programs. So there's work going on, but some of it's dependent on funding, and it's scattered throughout programs and areas. So it's very important to ask that question. I'm so glad you did, and hopefully we'll see more encouragement for all health professionals to have some kind of opportunity to specialize in geriatric health care.
And there's an additional question about incentives for nurses to serve in rural areas for a period of time. And there have been various grant mechanisms that have supported both BSN nurses as well as ARNPs to be practicing rurally. Again, inconsistent as far as funding mechanisms, but they do occur, and it's certainly something that we love to see when it does exist.
In response to Maggie's question, Chandra, I'm not sure how to pronounce your last name, Wajdik, said as a clinical social worker, they were not encouraged in school to specialize in geriatrics, and issues of older adults were not represented proportionally in their perspective. So Chandra sought out a certificate in age-friendly care and said that they're so glad that they did. And that's an opportunity. In fact, there is a new national specialty or certificate program for professionals in general. If you're interested in that, please send an email. I'm going to put the Northwest GWEC's email address here, and I can direct you to that program where people can do some study and then take a sort of a certificate survey quiz to be designated as an age-friendly health professional.
And there was a question about looking at the case study and what we discussed, and from experience working with elderly, if they're resistant to change and afraid of losing independence, how do you approach that? And given the rich discussion that we had in the chat, I would also welcome folks who are on this call to put what has worked for them in working with older adults who are resistant to change. It is a scary thing to think about losing independence. You can see from Carl, he had a strong independent streak, and we want to support that. And what are some ways that we can support that? And having these discussions starts to build those trust with the older adult. And then you can start to look at what changes could possibly be introduced. But also, there's a lot of choice here for Carl. And I think in some cases, folks have jumped immediately to Carl needing to be moved closer to his family. Maybe that's not the answer. Maybe that's what he's scared about. So having those discussions and opening it up to what are the possibilities within his own community and with what matters to him.
I also wonder, in your experience or in your current settings, how do you communicate and discuss these issues with other members of the healthcare team to acquaint them with what you're learning, as well as what maybe still needs to be information that still needs to be assessed, and so how to get that into an encounter? Does it just happen all through the EHR? Are there handwritten notes? Are you connecting with people in the hallway, or do you have meetings in which you connect to discuss some of these issues?
For the entire group, Barb?
Yep.
Hmm.
And actually, Maggie brings up an important point about families, how to get them engaged in the process and yet still follow HIPAA guidelines. So, Jordan, the question I asked was, in your experience or in your setting, how do you discuss and communicate these 4M's considerations? What information you find out, or what information is still needed, to other members of your healthcare team?
Mhm.
I like the idea of stand-up meetings about caseload and review of care plan needs, and putting concerns in a note for the provider to co-sign. It just seems like the EHR, the electronic health record, can be used, but sometimes is cumbersome to use for some of these kinds of communications.
Mhm. Nice to see a review quarterly.
Amy, what does the IDT mean? Interdisciplinary team? Okay.
And Maggie, I also just want to highlight your note there about having someone who does not have the family agenda and how helpful that can sometimes be for
Mm-hmm.
patients.
Well, Dr. Souza, I just really want to thank you for providing an amazing foundation for the General Geriatrics Healthcare Series this term, and acquainting us with age-friendly healthcare and what it all means. And thank you, thank you, thank you to all of the attendees for your engagement today. I look forward to the next lectures that are coming up and hearing and learning more from you. And we will see you next Thursday at 4 o'clock Pacific time. Thanks much.
Thanks, everyone.
night. Yeah, I put my, I'm not sure how to pronounce your name, Rabil. I put my phone number in the chat to you. I'm going to put it in again. Why don't you give me a call? All right. Have a nice evening, everyone.
Thanks so much, Barb.
Thanks,
Bye-bye.
Anita. See you tomorrow.